people who were living in the community with violence and using either clozapine, risperidone, or olanzapine. And all of them worked to reduce aggressive behaviors. Another study, they looked at treatment-resistant schizophrenia, and again, clozapine was better than both olanzapine and risperidone in reducing aggressive behaviors. And then lastly, one of the few studies that did look at early onset schizophrenia, and they were also having aggression, and they were non-responsive to either olanzapine or risperidone, that violence actually got better with clozapine. So clozapine seems to be like the thing to use in people who are psychotic and having aggression, especially if they're not responding to one of the other atypicals. So, however, you know, clozapine has a lot of black box warnings to it. It's really kind of a nasty drug that way. So we might want to think about using the medications that are, to start with the medications that are approved for use in younger patients with schizophrenia, and then if they're not really responding, then think about using clozapine. As far as tic disorders, Dr. Murphy again is going to talk about this, but really, what's the priority? What's the main issue? Is it really tics? Is it really OCD? To address both tics and aggression, we can think about using one of the atypicals, and of course, a lot of people prefer to start with risperidone nowadays. As far as IED, not a lot of really good studies. Most people would pretty much treat it like you would treat bipolar disorder, but Dr. Tobin's going to hopefully set this straight for us. But my preference is really to start with a mood stabilizer as opposed to an atypical antipsychotic. And again, I'd like to hear what other people have to say about that. And then as far as the personality disorders, we don't have very much about younger people, but from the adult studies, there was one that showed phenytoin was effective in male prisoners that were antisocial. So insufficient data regarding antisocial personality. We can't diagnose it under 18 anyway. As far as borderline pathology, over 1,700 participants in this. You're looking at both the older and newer antipsychotics, mood stabilizers, antidepressants, and omega-3 fatty acids. And they didn't look at aggression per se, but they looked at anger. So they looked at mood discontrol. And pretty much everything except, well, actually the atypicals, the new generation antipsychotics, mood stabilizers, and the omega-3s actually helped. These are really single effect estimates, and so we don't have any replication studies to see if this is real or not. Antidepressants are not really overall supported for the use of borderline pathology. Maybe helpful in the presence of certain conditions like depression and anxiety. And the total severity scores were not influenced by any antidepressants or any other drug. Not surprising. This is a meta-analysis that looked at with borderline personality disorder with or without schizotypal personality disorder. And they looked at these symptom clusters called either impulsive behavioral dyscontrol and affective dysregulation. And anger did get better with the use of antipsychotics and mood stabilizers, but the mood stabilizers are the ones that help aggressive behavior. All right, real quickly, developmental disorders. For IDs across the board, pretty much good data for the atypicals, and we know that by extension from the autism studies that we're really looking at things like risperidone and aripiprazole. But for IDs in general, especially if you see psychosis or autistic features, really want to think about using the atypicals. And then if that's not working for the ASDs, then thinking about Depakote. For fetal alcohol, again, because of the high rates of ADHD, think about using the stimulants first. A fair amount of anxiety in fetal alcohol kits, so think about SSRI. And then also can be a fair amount of autistic features too. Think about using an atypical. That's Randy Hagerman's stuff, UC Davis. And then Fragile X syndrome. This is where we might want to think about actually using the alpha agonists first. And then maybe the atypicals for Prader-Willi. This one kind of, when I first looked at this, say, well, Prader-Willi kids eat a lot, and atypicals kind of promote appetite. But But these folks thought that the risperidone worked pretty well in reducing aggressive behaviors in the Prader-Willi kids. And then on the other end of the spectrum, as far as appetite, these folks found that topiramate was helpful. As far as tuberous sclerosis, high rates of epilepsy, so thinking about starting with the anticonvulsants, which are also mood stabilizers, and then if not effective, using the atypicals. As far as Smith-Magenis, again, high rates of ADHD, so using the stimulants. Again, a fair amount of anxiety using the SSRIs. Also some seizure problems, so anticonvulsants, and then thinking about risperidone. And then finally, the Cre-Do shot, no real medication studies for this group as far as aggression is concerned. So my final comments, and I think this might be something we think about in general, as has been alluded to, was alluded to earlier. Want to treat underlying conditions, want to start behavioral interventions, we want to start low and go slow with meds, we want to dose to the person, not necessarily following rigidly some kind of guideline. We want to monitor very carefully for side effects. We want to try to avoid use of multiple meds whenever possible. And we want to consider medication holidays whenever it's reasonable to do so.